This episode is sponsored by PAX, the gold standard in emergency response bags. So when you're working under pressure, you need kit to be both dependable, tough and intuitive, and that's exactly what you get with PAX. Every bag is handcrafted by expert tailors who understand the demands of personal care, from the high-tech, skin-friendly and environmentally responsible materials to the cutting-edge welding process that reduces seams and makes cleaning easier. PAX absolutely puts performance first. They've partnered with 3M to make perfect reflective surfaces for better visibility, and bright grey interior makes finding kit effortless and fast even in low light. With over 200 designs, PAX bags are made to suit your role, your needs and your environment. And thanks to their modular system, many bags work seamlessly together no matter the setup. PAX doesn't chase trends, their designs stay consistent, so once you know one, you know them all. And if your bag ever takes a beating, their in-house repair team will bring it back to life. PAX are built to perform, made to last. Learn more at pax.bags.com or head to the show notes for further details.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Welcome back to the podcast. Today I'm with Radu Venter. He is a paramedic and pre-hospital colleague from across the waters from Canada. We're here today really just to discuss some of his fantastic blogs that he has on Substack. So on Substack, Radu goes by the name of the Paramedic Philosopher. Radu, welcome to the podcast.
Thank you very much for having me.
So the first blog post we're going to hear today really is around leaving room for rougher edges, Radu, in EMS, and when good enough is good enough. And it's a fantastic blog. And I just really wanted to sort of unpick it with you, really, because I think perfection can be the enemy of good enough sometimes. And especially when emergency calls and the nature of the job is quite fluid. And also, you know, just with the fundamental flexibility that you need as a pre-hospital practitioner. Could I get you to speak to the piece?
Yeah, for sure. A lot of it has to do, I think, with specifically, I'm a Canadian paramedic, so all my training is kind of North American focused. And I noticed when it came to school, there was a lot of focus on kind of getting the right answer. And it was critical that we got the right answer the first time. And I think it creates kind of a complex within a lot of us as practitioners that there is sort of quote unquote one correct answer, and that we have to keep going for that answer. We have to make sure we meet all of the requirements along the way. And I've noticed this not just in school when I had classmates afterwards ask, well, what did you do in that scenario? Well, what did you think was the right first treatment kind of thing? And we would all kind of align under what the right answer was. And earlier on in my training, specifically at our basic life support level, usually the answer is really easy. It's usually very straightforward because there's only so many procedures, so many therapies we can provide that, well, of course, you're going to be giving these medications for the allergic reaction. Of course, you're going to be giving these medications for the asthma patient. But as I moved up into both my advanced care and into my flight background, it gets much more fluid. It gets much more flexible. Well, I have 2 or 3 different options to sedate my patient with. Well, why did I pick that one over this one? Which one's the correct answer? And that was the kind of thing that it tripped up a lot of my classmates, and admittedly, it tripped me up as well, because we were constantly looking for, well, if your patient, say, fell and they broke their hip, well, should you be giving morphine first, or should we be giving fentanyl? Should we be giving ketorolac? Should we be giving Entonox? And every single time my classmates would be asking the instructor, well, what's the right answer for this one? And then the next day it's, okay, well, our patient has broken their elbow. Oh, okay, so what drug are you going to start with, instructor? Because that's kind of what the way that our education has kind of geared us towards. And then specifically with the scenarios, expecting to make sure that we've done all of these different skills before we get to the hospital, which is always conveniently far enough that we have time to complete all of those skills. So it creates these kind of false perfectionism ideas within us as practitioners. And realistically, there's no such thing in medicine. Paramedicine is far too open. It's far too flexible. you're never going to have the same patient over the same distance with the same severity of the issues. So it's perfectly fair and perfectly reasonable to say, hey, I was very busy just trying to keep that person on the stretcher. I didn't have time to do vital signs every 5 minutes as my scenario might have expected me. Or I started with fentanyl instead of morphine, and it turns out the patient had a bad reaction. Oh, I should have used morphine. I'll know that for next time. And it's a lot of this black and white thinking that um, it's just unfair to the practitioner, because how could we assume that you would have known ahead of time that the patient would have had a bad reaction to fentanyl? How do you know that, you're going to have the time with the patient lying there completely still so that you can get every single vital sign that you think you need? Or, oh, I didn't get two IVs, I was only able to get one, kind of thing. And it's giving ourselves and our colleagues and our coworkers a fair amount of compassion, specifically because, well, we tried and we did the best that we could in the time that we had. So it's quite understandable. And I've said this to a couple of my newer colleagues, especially when I was still working on ground, that it's not reasonable to expect all of these skills and all of these treatments will be done before you get to the hospital, because sometimes 5 minutes is way more time than you'll get. So of course, maybe you'll get the one IV and that's it. So you'll pull up and apologize to the nurse and say, hey, that's as much as we could get. We weren't even able to do any of the treatments because they were right next door.
I listen. I think you bring up an excellent point, Radu, and to your point, no two calls are the same. No two patients are the same, but also no two no two scenes are the same. And what do I mean by that? Like you say, there's pain differentiation, there's information entropy and differentiation. So the two different calls may, one, you might be able to get the patient history and all the collateral information quite easily. The other, not at all, because the patient is obtunded in some which way, or there's no family on scene. And you're right. So the piece, what I love about the piece is, like you say, you call for self-compassion in the piece, because there is a prescriptive endpoint, but it's okay to not be able to get to that endpoint because of the nuances, because of the details, and because every situation is different. It's a fantastic reflection. Have you had any post-blog reflections, or indeed any feedback from crews that have read the piece?
Unfortunately, I don't get as much engagement with my pieces, so I don't have too much. I don't get too much of that way in the way of feedback. But specifically, when I do share these thoughts with colleagues, I tend to get a lot more engagement and understanding and kind of appreciation from them, that there's no kind of perfect expectation, that there's no that even actually, as you just said, because no two calls are the same, no two practitioners are the same. So a new, even a newer paramedic might walk up onto a scene and instantly have the answer because they happened to see it yesterday. Or the seasoned and experienced practitioner will walk up on a scene and know exactly what to do right away because they've done a number of these. So it's often unfair to be judging ourselves to the standards of other more experienced practitioners, or others who have just happened to have had the chance of, I'm the cardiac guy, for example. I've only ever seen cardiac calls. Of course, this practitioner will be seasoned on a cardiac call, but is going to struggle on an asthma related call because they just don't give that on the regular. They're not familiar to how these things work. And so I've often done that with my colleagues, and I've said, hey, you had a 5 minute transport time. There was nothing more you could have done, or that call was so hectic. Of course, we forgot the temperature, or of course, we forgot something else here and there, because that's just to err as human, or not necessarily to err, but just to have such a task overload or to have such a cognitive overload that some of the finer points get missed. That's quite fine. Um, and it's often, oh, we missed the temperature. That was normal. Oh, we missed the blood sugar. That was probably also normal. It's rare that, the things that we kind of harp on ourselves are, oh, I should have known that that dose would have had too many side effects. I should have started with a half dose. Well, now. And I've often seen coworkers who have criticized others for, oh, well, you should have known this or you should have known that. And it's, well, we're kind of already talking after the fact. So whoever's speaking has the benefit of hindsight. We know that this call is going to go well despite the mistake we make, or we know this call is going to go poorly in spite of us taking care of everything. So it's important to kind of keep in mind, well, what would you have done differently? Well, speaking with the benefit of hindsight, speaking without the benefit of hindsight, it's often hard to, be able to hit that kind of reasonably and compassionately for our coworkers so that we don't, you know, kind of beat them down and get them feeling like, oh, you made a big mistake or you erred, when it was really just you did the best that you could in that situation. And maybe now you've gained a valuable lesson from it, or maybe now you've just got that little bit of, oh, let's see how much more I can take on the next call because, I've handled this level of, you know, hectic scene or cognitive overload or something along that line. And then that way we can kind of build up each other rather than kind of get very rigid, very strict with, and I've often talked about this with colleagues to say, well, did the first dose work? No, give another, because there's no way for us to know, like you said, all these different, even just like the different level of pain that will be enough to just completely throw off a call relative to a different call. So yeah, so at the end of the day, it's all just about that, you know, being able to accept that we are all going to forget something at some point. We will never have a perfect call, and striving towards that perfect call, I think, misses the mark of, getting all the little things that happen along the way, being adaptable enough when the situation requires you to, because no one's ready for everything. And, that's not a bad thing.
Yeah, absolutely. And it also falls in line with your concept, really, of being a reflective practitioner already and calling forward, like you said, lessons learned into future calls. But to your fundamental point, not being self-compassionate, not beating yourself up, understanding, like you said, you're not always going to get it right. And actually, even on the nuances, it's just being able to reflect and call forward some of that learning for the next patient, or indeed for the next number of patients. But one of the best aspects of being a practitioner is, in a way, making sure that they say the best F1 drivers leave the last corner behind them, being able to zero any errors and actually move forward, and not let those errors color your future practice, and actually, just like you said, being reflective. So actually, it's a fantastic piece. You're just about to hear it in AI format. We do welcome any comments. You will see the blog in the show notes, so I'll put the link to Radu's fantastic blog in the show notes. Radu, it's always a pleasure. Thank you.
Thank you very much for having me.
Welcome back, everyone, to the deep dive. Today, we're jumping into a pretty intense world: emergency medical services, EMS.
Right. And specifically, this fascinating tension you see there.
Yeah, this kind of push and pull between needing absolute perfection, like zero mistakes.
Which you can understand, given the stakes.
Exactly, life and death. But then there's the reality on the ground,
Yeah.
which is, well, it's messy. It's unpredictable.
It really is. It forces this conflict between following the procedure perfectly and, just doing what needs to be done right now in chaotic circumstances. It's not just medicine. It feels like it gets to the heart of professional identity.
We found this really insightful piece. It's called Leaving Room for Rougher Edges in EMS. And it takes maybe a more philosophical look. It challenges that really strict, almost checklist approach these professionals often hold themselves to. So, okay, the real question we're trying to unpack here is, when you're in that kind of situation, high stakes, not enough time, maybe not enough hands, when is good enough actually? Well, good enough. How do they square the textbook with the street?
Yeah, and that's our mission for this deep dive. We want to get into the why behind that internal pressure. Why do they often aim for standards that are, frankly, almost unreachable? And maybe look at what gets sacrificed, mentally, emotionally, when the choice is made. And it often has to be made to focus on critical care over ticking every single box.
Because that choice happens all the time.
Constantly. And the self-critique afterwards, it can be really tough.
Okay, let's talk about that self-critique. The source puts it really starkly. It says, after a tough call, there's nothing worse than a call where something was missed.
That feeling lingers.
It's this sense of having failed somehow professionally, even if the patient actually did okay, outcome-wise.
And here's a crucial point, I think. Often it's not that they missed a major life-saving step. That's not what they're necessarily beating themselves up about. Right. The smaller things, procedural gaps, things that, looking back, didn't really change the immediate outcome for the patient, but they violated that internal standard of absolute thoroughness.
Exactly. The article gives these great examples, like maybe you have a patient, clearly a medical emergency, but they feel okay temperature-wise. Nothing suggests a fever or hypothermia.
Okay.
And the paramedic doesn't grab a temperature reading. It's on the protocol checklist maybe, but in the moment.
It gets skipped. And even if, objectively, that temperature probably wasn't the make or break piece of information right then.
Right.
The fact that they could have gotten it and didn't, that's what fuels the criticism later. It's that deviation from the perfect standard they have in their head.
Or another one, they mentioned the obscure question. You've got someone say, middle-aged, classic, crushing chest pain.
Textbook
Not
start.
busy, ECG, maybe oxygen, get ready to move.
Totally focused on managing that immediate crisis. And then later they're kicking themselves because they forgot to ask about, I don't know, family history of early heart attacks. Something that might be relevant contextually but wasn't going to change the immediate treatment plan in the ambulance.
Yeah.
And that intense drive for improvement, looking back like that, it just leaves zero room for any flexibility. Or even, a bit of self-compassion. They're aiming for this standard of completeness that few other people expect, as the source says.
That's interesting. So the nurses, the doctors, the family, they're focused on the outcome. Did the patient get better?
Largely, yes. They care that the patient is stabilized and gets the care they need. The paramedic, though, often gets deeply invested in the process. How perfectly was every single step executed?
Even when that process has to bend or break because of the reality of the situation.
Right. They end up judging themselves against this impossible, idealized checklist instead of the actual clinical reality of stabilizing someone in an uncontrolled environment.
Okay, so if they're getting hung up on a missed question or a skipped, maybe non-critical vital sign, maybe it's because they're trying to apply rules from a controlled setting to something that is fundamentally uncontrolled.
That's exactly where the source goes with this brilliant analogy. It calls paramedicine an open sport.
An open sport. Okay, explain that.
Well, think about, say, basketball. Or maybe bowling. Those are closed sports. The court, the lane, it's always the same size, the rules are fixed, the timing is predictable.
Gotcha. Controlled environment.
Right. Paramedicine is the total opposite. The field is never the same twice. It could be a tiny bathroom, slick with water. It could be the shoulder of a highway at night, cars whizzing by. A hoarder's apartment.
Wow, yeah.
No two calls are identical. And that means those systematic checklist-style procedures, they constantly run up against the need for, immediate on-the-fly improvisation.
And that makes training really hard, doesn't it? How do you train for infinite variability?
It's incredibly tough. Training scenarios, they have to be somewhat controlled, right? You use actors, maybe a staged environment. There's a defined start and end.
They don't really teach you how to deal with sheer chaos or the specific way resources just evaporate in the real world.
Exactly. A training dummy doesn't scream at you. The scenario doesn't usually account for, the patient's 3 panicked family members all asking questions at once while you're trying to work.
Or the physical environment itself.
Right. Can you even get the stretcher into the room? Do you have to carry 50 pounds of gear up 5 flights of stairs first? Is your partner stuck dealing with traffic or an aggressive bystander?
So you're making constant real-time decisions about what's absolutely essential right now versus what can wait or what just isn't going to happen.
You have to.
Right.
And trained scenarios, while valuable, they can't fully replicate that pressure cooker of timing and resource management. In training, you usually have enough hands, a stable setting, time to think. Reality is often less accommodating.
And you see that variability just in the timing itself.
Yeah.
Right? The source talks about the huge range in response time.
Oh, absolutely. You could have a really critical call, like a major trauma, literally right next door to the hospital.
So that's just get them on the stretcher and go.
Pretty much. A scoop and run. You stabilize the absolute essentials, airway, breathing, major bleeding, and your main job is transport. Lots of tasks get deferred to the ER.
Okay. But then contrast that.
Contrast that with, say, an interfacility transfer. Moving a stable patient, maybe they're on a ventilator but stable, from one hospital to another one in the next town.
Right. Much more controlled.
And you might have, an hour, maybe more, of just driving and monitoring. The source even jokes that sometimes you have too much time. Enough time that a paramedic might actually,
Catch up on some reading.
maybe glance at their phone, yeah. Obviously while still monitoring, but the intensity level is completely different.
That mental gear shift, though. Going from 0 to 60 on one call, managing utter chaos, to then maybe having an hour of relative calm on the next. That's got to be demanding.
Immense. It forces this constant hyper-awareness of time, resources, priorities. It's a level of cognitive load that most jobs just don't involve.
And that brings us right back to that core tension, doesn't it? The choices you have to make under pressure.
Exactly. What happens when that clock is ticking, the situation is critical, and you literally cannot do everything the protocol might ideally call for?
This is where it gets really sticky, I imagine.
Right.
The source poses this question. Is it okay, is it acceptable for some tasks to just not get done if the team is flat out busy with resuscitation and doesn't have the spare capacity?
Logically, you'd say yes, right. Saving the life, stabilizing the patient, that absolutely comes first.
Of course.
But that burden of perfectionism we talked about, it often twists that necessary compromise into a feeling of failure, like, I should have been able to do it all.
And that feeling probably crystallizes during the hospital handoff.
Oh, absolutely. That's the moment of truth, in a way. You're moving from the open sport chaos of the field
Right, the unpredictable street.
into the very closed sport, highly standardized, data-driven environment of the emergency department. And you have to be honest about what you did and maybe what you couldn't do.
That sounds incredibly vulnerable. Having to say, look, we tried twice for IV access, couldn't get it, or the patient was too agitated to give us a full medication list.
And that honesty is vital for the patient's continued care. The ER team needs to know what's been done and what hasn't. But for the paramedic, it can feel like admitting inadequacy.
Even though the reason might be totally situational, not about skill.
Precisely. They're stepping onto that closed sport field where checklists and complete data are highly valued, and they feel judged against that standard, regardless of the open sport realities they just face.
Okay, but hang on. If the patient's alive, they're stable, they made it to the hospital.
Yeah.
Why does that handoff become such a moment of judgment? Does the system itself kind of encourage that feeling of shame?
I think it often does, yeah. Maybe unintentionally, but the system values efficiency and completed tasks. And the reaction the paramedics get when they report those shortcomings, that can really reinforce the pressure.
What kind of reactions are we talking about?
Well, the source basically highlights two potential responses when paramedics are upfront about things they couldn't achieve. The first one is, collaborative, productive. The nurse just says, okay, got it. We'll handle the IV here, or understood, we'll get the full history now. That acknowledges the situation and moves care forward.
Okay, that sounds ideal, supportive.
It is. But the second reaction, that's the one that feeds the self-criticism. The source calls it the raised eyebrow.
Ah, that subtle judgment.
Exactly, that look. Or maybe the nurse immediately says, okay, let me get a shot on those veins that stumped you guys.
Oof, yeah.
Even if it's not meant maliciously, it comes across as an instant critique. It implies the problem wasn't the situation, the difficult veins, the chaos, but maybe a lack of skill on the paramedic's part.
And that just reinforces the idea that they should have been perfect out there.
Totally. It pushes them right back into that cycle of thinking they failed to meet a standard that was reachable somehow. It encourages aiming for absolute infallibility on the next call, even if achieving that means cutting corners elsewhere, or maybe not being as fast, or diverting focus from the absolute priority.
It's understandable wanting to seem competent, especially when so much is riding on it. But it sounds like chasing that image of perfection can actually get in the way.
It can hinder the core mission if it leads to covering things up, or prioritizing tasks over stabilization, or just burning people out with impossible self-expectations. Honest communication gets sacrificed for the appearance of flawless execution.
Which leads us to the big takeaway, I guess. If we accept that paramedics are human, they're working in these incredibly tough, unpredictable conditions.
Yeah.
What should the highest standard be, if not absolute perfection on every task?
Right. What does this all point towards? The source suggests that maybe the standard needs to shift. It's not about clinical perfection in every single checklist item.
It's more about integrity, honesty.
Exactly that, relational integrity. The most valuable standard, perhaps the only truly achievable one in every situation, is openness and clear communication. As long as that paramedic can clearly articulate why something didn't happen, look, I was managing his airway, that took priority over the IV attempt, or the scene wasn't safe enough to stay longer for a detailed history. That transparency, that's the gold standard.
So being able to explain the rough edges is actually more valuable than pretending they don't exist.
Precisely. Because that communication ensures continuity of care, the ER knows what needs doing. And just as importantly, it fosters critical thinking about what success really looks like in that fluid, open sport environment.
Success isn't just ticking boxes. It's saving the patient, stabilizing them, and then communicating clearly about what happened and what's needed next. Embracing the necessary compromises, not hiding them.
Yeah.
Wow. That really reframes things. It's a fascinating look at the immense pressure on EMS teams. We've covered a lot. The need for flexibility in that open sport, the limitations of training sometimes, and how crucial yet difficult that honest communication can be, especially during the handoff.
Yeah, and while we focused on EMS today because it's such a high-stakes example, this whole idea, it really applies much more broadly, doesn't it? So a final thought for you listening. Think about your own field, your own work, maybe even your personal life. Where are you holding yourself, or maybe your team, to an impossible standard? A standard based on a perfect, closed sport ideal when reality is much more messy and unpredictable. And maybe ask yourself, how much better could things be, your performance, your team's performance, your own mental well-being, if you shifted the focus? If you prioritize being radically open and communicative about limitations, about necessary compromises, about the rough edges, what rough edges are you currently refusing to accept, maybe because you're worried about that raised eyebrow? Something to think about.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.